Good morning. I'm going to talk to you today about BIS monitoring and the anesthesia we use at the Center for Laparoscopic Obesity Surgery. One of the critical concerns about anesthesia is the potential risk of awareness during the anesthetic administration. And a lot of things have been written about it, and a couple of things that we do are designed to protect the patient from intraoperative awareness. A recent study from the New England Journal of Medicine looked at two techniques to protect against awareness, and they used what's called the BIS, or bispectral monitoring system, which gives an integrated version of the electroencephalogram, and measuring the end-tidal anesthetic gas. And their big conclusion was, at the end of that study, was they couldn't tell any difference. And so they concluded in that study, well, that the BIS monitoring was unnecessary or not very good. Several letters to the editor in the recent New England Journal argued that their conclusion that there wasn't any difference was based on a fairly small study that didn't have the power to make such a conclusion. And so because of this, we feel like that particular study has inadequate power to guide our practice. There are a variety of things that can predict the increased risk of having intraoperative awareness. One of them is the type of anesthesia. The anesthetic that we use, called TIVA, or total intravenous anesthesia, is something that's quite safe, but has been reported in some studies to have an increased risk of intraoperative awareness. To protect against that, we use the BIS monitor to maintain a decreased level of awareness by titrating or adjusting the type of and the dose of anesthesia. In addition to that, one of the problems with intraoperative awareness is the patient can't respond and tell us that they are feeling something. So one of the things that's nice about our anesthetic technique is in about 90% of patients we use no paralysis. So the idea there is that if you're paralyzed and getting an anesthetic gas that's not adequate, there's no way for you to alert the anesthesiologist or the surgeon that you're not feeling well. If you are not paralyzed, that allows you to kind of tap your hands or move or show that you're awake and that you're feeling discomfort and that there is some presence of intraoperative awareness. So we use a combination of techniques. We're still impressed by the value of supplemental use of the BIS bispectral monitoring. And in addition to that, most of our patients are not paralyzed. The other big advantage of not using a paralytic agent is it doesn't inhibit breathing post-op. A paralytic agent has the potential risk of lasting longer than expected. If this happens, then the post-operative patient, especially if they have morbid obesity and concomitant respiratory restriction because of their obesity or other pulmonary problems, then the combination of the paralytic agent and its impact on the respiratory function post-op can lead the patient into some dire straits, some complications like low oxygen, irregular heartbeat, a need for re-intubation as an emergency, or even death. By avoiding paralysis, by using relatively short-acting drugs for the anesthesia, and by using relatively longer-acting drugs that are respiratory stimulants, we found that we can perform a very safe, very protective type of anesthesia that leads to a very high level of patient satisfaction. We're very interested in further articles on the BIS monitor and protection against intraoperative awareness, and we're very satisfied that our results are excellent using this technique. I hope you're interested, and if you have any more questions, don't hesitate to either send us an email at drr, that's Dr. R, at clos.net. That's our website, clos.net, like close the door, or call us, and we'd be happy to talk to you further. Take care.